All right, thank you, Alicia. Good morning and good afternoon to everyone who's joined. Thank you very much for joining this educational webinar. So today's discussion, we'll call it a discussion, is about tissue processing, and from conventional overnight processing all the way to continuous rapid. So what are we really talking about? And if you've had any of these other educational webinars from me, I'm all about trying to get us to rethink our histo process. I like to call it histology process improvement, but what are we talking about with tissue processing? It really starts with your sample selection, most important, your tissue fixation. One of the issues that I see with what we do in most of our laboratories is that we're combining processing with fixation. There's fixation on your processor. It's a compensation that we're making. Then you've got tissue dehydration. Another issue I see is that most of us use some sort of reagent alcohol, ethanol, methanol. And I would want you to think about why not isopropanol. It's something just for food for thought. Then we must facilitate our paraffin infiltration. We've got to create structure back to those tissue samples. So what we're talking about here in tissue processing is optimized and consistent microscopic morphology. There's all kinds of things that if you've gone through a formal histotechnology program, if you've been in histotechnology for a while, there's all kinds of information out there about what is the optimized and consistent morphology. But in today's lab, you also have to look at what's your optimized workflow. And unfortunately, for most of us and most things that we do in histology, most of our techniques were probably developed in the early 1800s and really haven't changed much. We have some update of some instrumentation, things like that, but we really haven't had a big change in a lot of our techniques. And I'm going to tell you it's time that we reconsider some things. So, what tissues are the first things to consider? What tissues do you process? Are you a specialty lab? You do just biopsies? Are you a cancer center and doing tumor tissues? Derm lab, general hospital lab, surgical resection, some sort of specialized tissue? Are you a combination of all? That's not unusual also. But tissue samples, for us to have best tissue processing, tissue samples require standardization and precision. And especially as we move to more utilization of immunohistochemistry and in situ hybridization, there is a big difference of performance of a tissue section on a slide if one end of the tissue was 5 millimeters and the other end of the tissue is 1 millimeter. They will fix at different rates, they will process, they will look differently. As you get to more specific techniques to develop your diagnostic and now prognostic information that you want to give out on these patient samples, it really does require that we standardize tissue samples. The other thing you need to consider is what type of histology lab are you? One process doesn't fit all of us anymore. Are you would you consider yourself a routine lab? Specialty lab, hospital lab, reference? What type? What are you really trying to achieve once you receive that tissue sample? And it absolutely matters. You have to figure out what you're trying to achieve at the end point of your workflow, of your process, before you can really optimize what you need to do. Is the use of a conventional instrument, whether it's one of the variety that are out there that you load it up at 5 p.m. in the evening and it magically comes off at 3, 4, 5 o'clock or some other time in the morning. That's an accommodation for different reasons, but does that particularly work? Could you take that conventional processor, a microwave processor, a continuous load processor, and then reorganize your workflow and actually affect patient care and turnaround time? So you have to really think about what are you in a histology lab. I mean, if you have a good portion of diagnostic biopsies, what are you doing different for them? So there's lots of things here to consider today. Unfortunately, I'm not going to give you all the answers, but I think it's time that we start looking at this, about what are we doing, why are we doing it, and what are we trying to achieve? And not always is our histology lab set up that way. Most of the other processes within healthcare are set up with taking those things into consideration. So you do have to look at is what's your workflow. Is it what we call standard conventional, that you have specimens that are tied directly to surgery in your institution, or a surgery center in your institution, or off-site, and it comes in throughout the day. They go through the process of gross dissection, dictation. They get into a cassette. Everything is organized into a batch and then placed on one processor. That's what I would consider standard conventional. There's issues with that in today. Again, with the increased specificity and the different type of techniques we want to do, do you see the variation that much with your H&Es? Maybe, maybe not. But your performance of some of these more specific tests that you have, yes, you start seeing variation. And then it doesn't necessarily mean that you have a problem with processing. Your processing may not be specific enough for what you do. Are you a rapid response? I've run into many labs now that they're just doing certain types of biopsies and they need to turn those around the same day. Well, you certainly have to look at your workflow and the instrumentation that you use. Are you unique? I think most of us think that our lab is unique. Our processes are unique. Our problems are unique. And then have you embraced lean? Are you doing some sort of other workflow management, some sort of quality management process, such as the lean, what is now popular, Lean Six Sigma, things like that? Then why does it matter? All of this matters because we are all moving towards, and we should, I think it's in all of our best interests, and we're kind of lagging behind in the histology lab. You have to be more patient-centric. You know, loading up your processor overnight is, when you look at that, or whether you're using a microwave processor or whether you're using a rapid processor, we have made decisions to use those, but did we really start our process of selection of why this is in the best interest of the patient? And I would say, and I would argue always, and you know how I like to argue, but I would argue always that we have not always set up our processes from the receipt of tissue through the review of pathologists in a patient-centric way. We are putting out quality patient results, but we've not designed our process, our instrumentation, the task and procedures to use with those instrumentation by looking at what's best for the patient first. So the other thing is, you also, before you select a tissue processor and decide how you're going to do your tissue processing, what type of staining do you do? What are you performing in your laboratory? H&Es and a few special stains, IHC, enzyme. What are you doing? Are you doing, if you're a specialty lab, and you may be doing a much higher percentage and level of patient samples that are doing special stains, IHC. You might be doing a lot more than just kappa lambda and site2 and trying to do those techniques. So all of this, if you're looking at this, it's all interconnected. You start with the patient. Again, why does it matter? You start with the patient. You look at what you're trying to achieve for those patient results, what you think, and it really does come down to what we think is going to give us the best outcome to produce the patient results required, and then you start working backwards. Typically, we spend this type of effort, this type of consideration when you buy an IHC instrument, but not so much when we move to tissue processing. And that part I've never really understood in histology is we'll spend all of this time deciding that we need to have all these bells and whistles and specifics and everything we need on an IHC instrument, and this is really stuck at the end of our process. And then we wonder why we have so much problems with these type of stainers, these types of instruments, because we just didn't go back to the basics again, fixation and tissue processing. And I suggest that what we're really looking at is how do we get to the most appropriate process for our laboratory. Now, the other thing is the most appropriate tissue processing for your laboratory very well may be a combination of tissue processors. That's not out of the question. That's not unheard of. Again, if you're being patient-centric and trying to make sure that your results are meeting those needs of the patient, and again, don't discount that you've got to have a customer in there, which is your primary customer, which is your pathologist. But again, you're being patient-centric. You may have a solution that is multifaceted. What we're really talking about is there's some things that you can do on benchtops. There's some manual process that you can do. But what we're really going to talk about today is those walk-away tissue processors. And what I call a walk-away tissue processor, that's something that you can place those cassettes. And we do have specialized cassettes nowadays. So you place the cassettes in a rack or holding receptacle. You're able to place it anywhere from 1 to hundreds of cassettes. Press a button. You've preloaded all kinds of reagents onto that instrument. You come back and you've been infiltrated into paraffin, so that you can move on to your next step. So the most popular, in my estimation, the Sakura VIP, from God knows what number you have all the way up to the 6. You've got the Leica ASP. There's a couple of varieties out there, including with their new one. The Polaris, the new Polaris, and that's very popular to use in rapid processing, but that's a conventional processor that's been adapted to rapid. And then you have the thermal Excelsiors and STP. So again, you need to understand what's out there. You understand what they were designed for and what you're going to use them. When we go to rapid, again, Polaris is very, very popular. Milestone, the Logos, is very popular. Microwave, if everybody's talking microwave, but the first thing they're going to talk about is either a benchtop instrument, but that's not a walk-away, even though there are a couple of systems that are getting very close on the benchtop, to the Milestone Pathos Delta. I think that's probably the most popular microwave, walk-away. That's actually a combination tissue processor. And then what I would term as continuous, that's the Sakura Express. That's an instrument that every 20 or more, depending on which model you have a continuous load. You're continually moving along and can continue to load other cassettes while you're in process. But when you look at this slide, and we look at from conventional rapid and microwave to continuous, the next biggest breakdown is that conventional rapid microwave on this page, there is a processing receptacle that all of the tissues are brought into, the tissues are placed into, and a variety of solutions are brought in and taken out of that one receptacle. The Express is multiple processing receptacles, and the tissues are taken from receptacle to receptacle. In the most simplest form, very similar to some of our first tissue processors that we had. Not everybody's as old as some of us, including me. But the reason I mention that is that the process, the technology, the logic, the theory behind the continuous load processor is absolutely updated with the Express instruments, but it is a proven process that we had before we came to the one receptacle and moving everything in and out. And there are issues with all of these instruments when you combine them with what's best to work for your patient-centric process and all of the other issues that you have in your laboratory. I will not say that one is better than the other. One is going to solve all your problems, all of your issues, but I can always tell you that when you're looking at any of your processes and your tissue processor, your stainers, whatever you want to do, there is one true theorem that comes out. If you have people or process problems, it doesn't matter what you buy off of this page. When you put it into your laboratory, you still have people and process problems. They're very good instruments. They're just not that smart and can't fix all your problems that way. So the thing is this is how I break down walk-away tissue processors from conventional to rapid to microwave to continuous. But we do have to back up. All of those instruments that we just talked about have a requirement of tissue sample and selection in being placed into that processor. Not to offend anybody out there, but I do have a term that if you're putting all of your different size types of tissues all onto one process at the end of the day and running it to come off in the morning, you're kind of doing Goldilocks and the Three Bears processing in today's laboratory. You have some that are just a little under-processed, some that are a little over-processed, and then you have another group that's just right. The other thing is that what I've found over the years, and now that we've moved into small batch processing, that when you have a rack that is several hundred cassettes, even if they're all the same tissue type and size, you're going to see that effect. You're going to see that the ones on the outside tend to be a little bit more over-processed than the ones on the inside. And I think that that was one of the realizations that I came to, is that small batch does allow you to be much more precise. So working with a batch of 1 to 20 cassettes allows you to do things, many more things, than if you're working in a batch that's 200, 100, 300. You know, I kind of look at any instrument anymore as I move through with the workflow and trying to do the lean, and that is that I really don't care what the capacity of an instrument is. What's its capability to move to the next batch, whether it's a large batch, small batch. What's the capability, not necessarily the capacity. I think it's great that something can do 350 cassettes at a time. If I'm being patient-centric, do I need 350 cassettes? So let's get back to where we need to start, and that's your fixation times. You know, tissues must be segregated by size and type. They really do. An endoscopic biopsy that isn't unusual to come at you at 0.1 or 0.2 millimeters does fix at a different rate and processes at a distant rate than a diagnostic biopsy that might be a needle core biopsy, that might be a skin section, the tissue resection. So this is typically where I segregate, is small diagnostic biopsies, needle core, skin, and then resection tissue. They're different sizes, they're different combinations of tissue types within those samples, and I think that they need to be looked at and treated differently. And very hard to combine those all. Again, if you're trying to combine them all onto one processor, one process, you're not going to see optimal results. You're going to see a bigger variation and acceptable results, but in today's lab, is that really going to get us where we want to go, that we've got acceptable instead of optimal? You need to know when fixative is applied to your tissue. I hope everybody understands what cold ischemic time is out there. If you're doing breast sampling and you're doing ER, PR, and HER2/neu, what is one of the first things that ASCO-CAP tells you? You must know what that cold ischemic time is. It has to be less than an hour. My first question that came to me when I saw that is, so if it's critical on a breast biopsy, why isn't it critical on a different needle core biopsy? Why isn't it critical for a cervical biopsy, for a gallbladder that comes out? I think it is. I very much feel that it is very, very critical how long between resection or extraction from the living body to when it gets into your fixative will absolutely and greatly affect your performance. Go buy a $250,000 instrument, but if you don't have that part of the process controlled, you're going to see all kinds of variation. So we all need to find a way to work with the providers of our tissues that we need to know exactly, and by exactly I'm going to say within minutes. We need to know when the tissue was actually taken and when the tissue got into our preferred fixative. Most often that is 10% neutral buffered formalin. But we need to know that. And we should be putting that onto our reports, that if we don't know that our results may be suspect. If you're doing breast biopsy, you definitely have to follow all these rules. And the kind of way the way I've kind of approached it is, if I'm going to have that kind of precision and information and requirement and documentation for this one piece of tissue, why wouldn't that be acceptable for all the tissues? Think about it. Something to think about. It's not easy to do, and it's not a regulatory requirement, but if you're being patient-centric and you want to give everybody the best process that you have, these are the type of things that we need to move forward with in our histology labs. And then the other thing is volume of fixative. You got to have at least 20 times tissue fixatives. You got a large piece of tissue and you don't have that, you're really not fixing. And one of the things that we've gravitated to is that any resection tissue, we do not start a fixation time until it's into the cassette and then placed into fixative. Takes management, takes time. It's not as easy as just throwing it all onto the processor, adding your first 2 steps into formalin and hoping you catch up or at least get to a minimum time with your samples. Be precise, know what's happening to your tissues. I think you'll understand more what's going on with your processor, and it allows you to create more precision throughout the rest of your process. So fixation is very, very important. I am a big proponent that 2 millimeters or less is what you need. Think of it, if you're cutting at 4 microns and you have a 2 millimeter thick specimen, how many hundreds of tissue sections can you acquire from that block? And how many do you need if you have the most difficult case? You may need 10s or 20s or 30 or 50. Most often you're way over 700 and some odd sections that you can acquire from that tissue block. So small works, small gives you all the information. There isn't a testing protocol, that you can perform on a sample that is 2 millimeters or less. The other thing we have to talk about is what's the optimum fixation time? 24 hours, 12 hours, 6 to 8 hours? Isn't that what ASCO-CAP tells you, that you have to have a minimum of 6 to 8? That's a resection sample, typically. How about 4 to 6? What is it? What do you do? How do you control that in your laboratory? I'm going to tell you to have a diagnostic tissue sample, and being a long-term user of rapid processing for now almost 8 years with the high volume of samples going in there, 12 and 24 aren't absolutely necessary. There are minimum times that you have to look at. Once you get below a minimum time, you see a lot more variation. But once you get within a certain range, you're going to see less variation. You can create a diagnostic consistent sample in less than 12 hours, in less than 8 hours of sampling. But you do always have to make sure that you follow all your ASCO-CAP guidelines, any other product that you have that has a specific specification and suggested times. You must follow those to remain compliant or do a validation study outside of that. But most publications out there will state that 6 to 8 hours for a reliable result. There's a couple of new publications that went out that just came out this year. One is that 4 hours for all tissue types. That's a combination of 2 hours of room temperature formalin and 2 hours at 40 degrees. They published their paper. There is no discernible change in all the different tissue types, no destruction of the tissue, and then they're doing a variety of tissue processing from conventional to rapid. But precision in fixation and your sampling is going to be most critical about how you also choose which tissue processor you're going to use. So I'm sorry we spent a lot of time on tissue fixation, but it is most critical. I mean, if you went through a histotechnology school, if you've been in histotechnology for years, if you've learned anything off the internet, everybody tells you if you don't start correctly, you can't finish correctly. And most often, I find we'll all go out and buy a variety of expensive instruments, but then we don't even spend the time to get back to the basics. Is we didn't fix it correctly or create precision in that fixation protocol, we have too much variation. And then we often blame everything from the processor to the stainer to the tech. And most often it's just because we didn't spend the time that we spend at the end of our process at the beginning of our process. So consider that two-step method of fixation, 2 hours of room temp, 2 hours of 40 degrees. It allows you, what you're doing when you find these times that can help you develop precision and reduce down the time that samples will sit passively in solution, you're gaining back time into your lab for you to work with that tissue sample to create the best section, the best stain, the best result, which allows you to be more patient-centric. That's what all this about continuous process improvement, finding which processor works by segregating your tissue, by creating precision, that's what you're trying to do. And again, creating precision at the beginning, and then you also create precision throughout your process. And that's what we all want. I mean, you know, you really don't want to have all of these workarounds each step of your process. I like to use this example because people, how long is this? But you have to remember that if you have a 2 millimeter thick sample, diffusion takes less than 2 hours. Formalin, when it's in a liquid state, moves very, very quick. And if you're immersed for greater than or equal to 4 hours, you are going to have a very stable tissue sample that's going to allow you to move on to dehydration and then infiltration. And you're going to get a consistent diagnostic result. The walk-away tissue processors. Conventional, rapid, microwave, continuous, which one will work the best for your patient-centric process? Not one that works best for because we've always done it this way, or we don't want to add the effort up front. We don't have the time to do the effort up front. I just don't think that that's going to be acceptable for us as we move forward. You've got to figure out how you're going to do something a little bit different. But these are the ones that I think that most of us are considering. So tissue processing. What are the pressures on your process? Are you coming in the morning and the pathologist, your customer, the pathologist wants all your diagnostic biopsies? Well, if you're putting them all on the same processor, kind of hard. You're working in a big process. Now you've got to reorganize. You've got to pull things out. You've got to look for things. Why do you choose overnight processing? Is it best for your tissue? Is it best for the samples that you're working with? And then I always ask this, why have you decided to put fixation on your processor? If you took your fixatives off of your processors, spent the time to segregate your tissues, fix them appropriately within a tighter specification, you can all make your processors, whether it's the oldest conventional overnight processor or conventional processor to the rapid, you're all going to make them work much more efficiently. So you want precision processing. It's going to eventually move you to rapid processing, whether you're using an instrument that's designed for that rapid processing or whether you're using something that is an adjustment of a conventional. So you're moving from precision processing to rapid processing to conventional rapid processing. And I feel that once you start making all these changes, you're going to say to yourself, well, why am I letting any tissue sample sit and wait if it's available, if it's an appropriate process, fixation time and it's available to process, why not put it on? And I'm also a big proponent that why do I need more than 1 or 2 hours processing if I can then adequately, in a standardized way, in a consistent diagnostic way, produce that sample to paraffin in 1 to 2 hours. So you want to process the tissue when it's ready to process, not when it works best for us in our workflows. I think that's something we really have to consider in histology, is that it's, we have these traditional workflows. We've got to figure out how we break from that and find a way to do. You want to be able to process tissue when you are ready to work with it. Not, okay, now I have a large batch that comes off in the morning. Now we have to do all this workflow this way. You want to process tissues in small batches. I'm a big proponent of doing small batches. You want to process tissues in a lean workflow. Again, that lean workflow is precision processing, which starts with precision fixation, moves you to rapid processing, and then continuous rapid is the next step. Consider the effects of the type of processing that you perform. All right? Well, you get increased efficiency equals improved quality equals increased productivity. That has to be on everybody's mind. So I always use the example that if you have something that's sitting on a processor and it's not available for you to embed it, cut it, stain it for 3, 4, 5, as much as 10 hours longer than if you're doing continuous rapid processing, you've lost that time to work on your efficiency, improve your quality, and allow you to increase your productivity. When you get into precision tissue processing, you also will reduce your cost because you're not over-processing, you're not making decisions that are not patient-centric. You get less wasted time. Less wasted time means that if you process your tissues appropriately and to that type of tissue, you're not going to have to spend a lot of time cutting it. You're going to be able to make your stains the most efficient. You're not going to have to do all of that wasted time, which is also not value-added time. And I'm trying not to get into too many lean terms, but you want to be able, whatever it is, from the moment it walks into your laboratory to the moment that the pathologist reviews it, you want to touch it once, only touch it once, or only touch it when you add value. Adding value is adding a fixative to it, putting it on the processor, transferring the tissue from the cassette to the embedding mold, creating slides, staining those slides, and the pathologist reading the most appropriate sample selection or samples that will allow them to create the best diagnostic report. So more time to work with your tissues is what you're actually creating when you move into a more precise process. Again, precision, rapid processing, continuous rapid processing. So continuous rapid processing. I also ask everybody is rate. You need to find a way to rate your tissue processors, and there are tools out there that the clinical lab and other portions of healthcare use, and it's called overall equipment effectiveness. And it's a way to measure equipment based on measuring loss. And the things that you're looking at is the availability, what's your downtime loss, performance, speed loss, and quality, your quality loss. So if you investigate it, the internet's a great way to look at this to find out more about equipment effectiveness. But it was something that we've done, that I was asked to do, and look at the conventional processors to the continuous rapid. So we looked up and also tried to find out what is considered world-class. Well, for availability greater than 90%, performance greater than 95%, quality greater than 99.9. So when you put that all together in this equation, you put all your data into this, whether it's for a VIP, a Polaris, an AP, an Express. When you put all that data in, and the data will be different from site to site, but it should be specific to what you're doing at your site, so you want to see some variation. But all that said, world class is greater than 85%. When we calculated the Express 120, we looked at our operating time to the planned production time, our performance, our quality, and again, these were at the time of this study. They change daily, weekly, monthly, however you're doing this, but it has to be specific data. It's not something that you can look out there and there's one set of data that's going to be able to be applied. But I think it's valuable for you to use this in your specific lab and collect that data. But when we looked at that, the overall OEE was a 90.16. What does that number tell you? Is it the best instrument? Is it the only instrument? What does that number tell you? Well, when you use this lean process tool, it's telling you that if you score 85% or better, that instrument is going to help you in your lean processes and not be a hindrance. Does it tell you whether or not the sample is a superior sample or not? No. It just tells you that that instrument can work well within your lean process. So we also compared it to the VIP, to the Express, because we were using the VIPs. The Express scored, here's the difference. So we go through all of that, and your actual performance was the 90.16 for the Express and the 66.16 for the VIP. And I'm going to say the VIP is similar to most of your conventional instruments. Does it say that the VIP is a bad instrument? Absolutely not. The VIP and the conventional instruments that we use are the gold standards. They have always given us good quality results. They may not give us the precision that we need to move to, but they give us great quality results. But that 66 score compared to a 90% score says that the VIP or another conventional processor may not be the best to put into your lean process. And I think that's valuable information that we need to learn and see. Doesn't mean that to use this as the only tool to pick out a processor, but you need to know, is that process, whether it's a stainer, you can use this on stainers, is that tissue processor, is that stainers, that IHC instrument, is it going to help me achieve a new workflow and a lean workflow, or is at best it's not going to help and you hope it doesn't become a hindrance? So tissue processing, it's standardize the process. You want to remove your variation. You want to standardize your tissue samples and your fixation time. Thickness of your samples are very important. You can always be smaller, but you don't want to go larger. You want to use shorter fixation tissues. All tissues can be gross to specification, and all tissues can be rapid process. Use your rapid processing. No need to over-process. So again, when you think back to the slide with the tissue processors on that I mentioned, and this will be expanded to a half-day workshop, and we'll talk more specifically about all the processors. We wouldn't have time to do that in this 45 minutes. But what I'm trying to get everybody to understand is that you need to look at these things in a different way. You need to go out there and investigate what's available to you to either help you change, help you improve, help you create a better quality sample result, and you need to look at all of these with maybe some new eyes. There's value to having a process that has worked for you for several months, years. There's also value at looking at that process and is there something we can do different. So again, standardizing the process. Look at the instrument that you're considering, look at the instrument you're using, and how can I move to a more precision process. What I want to do is just put a couple of tissue micrographs here at the end. These were used on Express 120 and then scanned. As you can see, there is. These are rapidly fixed. These are rapidly processed, and we see great nuclear detail. You can achieve, with every instrument that was on that list, you can achieve precision processing. There are trade-offs by using what I consider a standard conventional to moving to a rapid to a continuous rapid. But if you start thinking in these different terms, I think that you're going to start leading yourself to that continuous rapid process. But you can create consistent diagnostic results. Breast invasive CA, again, crisp, clean diagnostic results with the IHC staining. HER2, how many of you looked at your HER2 slides and you see something that's not this diffuse? That you see many more overly stained, dark stained, everything else? I would say that this is a good characterization of what a HER2 sample should look like. It should be more of a diffuse stain. Again, rapid process. Cervical cone, Ki-67. This was the extended processing on the 120, 2-hour process. No need to have 6, 8, 12 hours processing if you standardize the fixation and the sample selection. Skin excision, standard processing, which is a 1-hour process. Melanin A, if you have a lot of melanoma cases, this is absolutely the stain that you're going to be doing. There are no obstacles, really, to moving to rapid or continuous rapid processing. There are no technical obstacles. There are people obstacles. Yes, you have to create precision and gather more data and demand precision in the sample selection, the fixation, and then the sample dissection. Those are typically what our obstacles are. Those are more people obstacles. And there's a variety of reasons why. This is not easy to do, but you can achieve a consistent diagnostic result, take away some of that processing time, create a new workflow, and create a precision process model for you.
Thank you, Bill.
Now it's your turn, Alicia.
Yes. And as with every webinar, we also have a featured product. So today's presentation was strictly based on tissue processing, and we had some focus on rapid tissue processing. We do have the only continuous tissue processor that is on the market, which is the Express X Series. It comes in 2 versions, an X50 for smaller to medium-sized labs and an X120 for larger labs. It does utilize microwave technology. The microwaves heat the reagent, not the tissue. It does not use xylene or formalin on the system. You can still fix in formalin, however, it's not loaded onto the system, and it meets Lean and Six Sigma criteria. At this time, I would like to transition to the question and answer phase. Bill, one of the questions that we have is, have you looked at or have any knowledge of the TISPA tissue processor that uses supercritical CO2 to process tissue xylene-free?
I have not had it in my hands. I have read some material about that and have had a conversation. At this point, I am very interested in that process, but I don't have a lot of firsthand knowledge with it. It's a newer process that's out there, and at this point, I say it's interesting and has some merit, but I don't have any direct experience with it.
Thank you. Next question is, how difficult is it to transition to rapid tissue processing while maintaining a minimum fixation time for ER/PR and HER2/neu?
Well, depending on what your volume of ER/PR, what we didn't have time to talk about is that whether you have 10 cases or 100 cases, why you don't want to design your process to one tissue sample. Say you have one, this will just be for argument's sake, if you have 1 or 2 breast cases a day, think of all the other tissue samples. What it actually allows you to do is absolutely work with that breast tissue sample, appropriately sample it, fix it, and then place it onto your processor. I'm a big proponent that that's why I like a continuous load processor. It doesn't matter whether I've already started 20 or 40 cassettes. In the most waiting time I'll have is 20 minutes to load on those breast samples. So you have to figure out, now if you've got a conventional processor, then you're going to have to figure out how to do some processing during the day in your histology program. It's okay to let it sit longer. I'm not a big proponent of letting them sit all the way out to 48 or 72. I will tell you, I think you're going to get different results. But you need to set up a process with whatever the tissue processor is that when that sample is ready, I have the ability to put it onto tissue processing and getting it to paraffin. Doesn't mean that you're going to cut it, stain it, and do it all the same day, but if you think of it, if you can take any portion of your samples in the same day that you receive them and could move them to paraffin, think how that will affect your workflow. So you, by setting up a continuous flow, a new workflow, you're able to address those specific and particular samples directly and more appropriately.
Thank you, Bill. As with all webinars, we do...
Lisa, can I back something up here? I think I maybe misunderstood that last question. If you're going to use the Express and you're using an FDA product for your staining, the Express does not have xylene. So after all those other things about your workflow, you must do a validation study. You can use any FDA product, not according to what it was approved for FDA, if you do the appropriate validation study and prove that you have correlation. So the Express does not use xylene, and the 2 products that are out there that are most commonly used, either the DACO or the Ventana, do have formalin fixation and xylene processing, xylene in their processing. You have to do a full validation protocol and prove that if you're going to use the Express without xylene, or even if you decide to change to a different fixative, that compared to you having samples run exactly as you have the FDA, that you can get a correlation. So I think maybe that's the other thing you were asking in the question.
Thank you.
Sorry about that.
No problem. Unless there's any additional questions, I think that would conclude today's webinar. Once again, thank you, Bill, for taking the time out of your schedule to present for us. I do have one more question that did come in.
All right.
And we do have time, so I'm going to ask it. When using the dissection tools to cut 2mm slices for the Express, was there an initial resistance to dissection?
Absolutely. It's a change in process, but here's a couple of things that can help you. If you are, we'll call it a combination lab, and you have, well, let's even say you're a resection lab. Most of your tissue samples are resection. You're probably only going to have to use the precision tools about 30% of the time. Several samples that you take are easy to meet that criteria, such as if you're cutting a gallbladder or an appendix, that's easy to create that 2mm or less. So the tools have to be learned how to use. That can take anywhere from a couple of days to, I don't know, several months if you have somebody who's a resistor. But what you'll do is you'll eventually move to using, if you're going to use the Sakura, and I will say that there are other tools out there, other manufacturers, but if you're going to use an assist tool that's going to help you create that consistent size and across the sample, you're going to learn to use, most commonly we use the tissue tack forks. You're going to use those just as a replacement of your forceps a lot of time. You'll have a blade and a forceps. It is a learning process, but it does demand, if you're going to go to rapid processing and you're not going to have all diagnostic endoscopic biopsies that are 0.1, 0.2, 0.3 millimeters, you will have to learn how to make that tissue sample. It is not something that everybody doesn't already know. Every PA who goes through their training and every pathologist is trained to do the nickel. If we could get everybody to get a nickel size, the same size, volume and size of that nickel, and consistently that thickness, I think all of our processes would work better. So there is resistance. It takes management, and it has the same issues of any change and learning a new process.
Thank you, Bill. I think that will conclude today's presentation. I hope everybody has a great day and a great rest of the week.